Hi, my name is Jamie Upchurch, and I am here to discuss improving patient flow in the emergency department setting. The emergency department is a dynamic environment that is constantly changing. It can be very intense at times, and the staff must be ready for anything. We encounter many high risk patients, including traumas, chest pains, patients experiencing stroke symptoms, patients in respiratory distress. There are many times when several of these types of patients will present at one time, including ambulances arriving. And as the emergency department staff, they have to be prepared to handle those situations immediately and, excuse me, know what to do for each situation. This can be very challenging mentally and physically for the staff. Most staff members work 12-hour shifts, and when you're working in a busy emergency department dealing with traumas, this can be very, very challenging mentally and physically. The emergency department is already a stressful area, and when the emergency department becomes overcrowded, this increases everyone's stress level, including the patients. Um, Unfortunately, emergency department overcrowding has become an international problem due to insufficient access to inpatient hospital beds and inadequate staffing ratios for physicians and nurses. According to the Agency for Healthcare Research and Quality, nearly half of the emergency departments across the United States report operating at or above capacity. This overcrowding and problems with decreased patient flow makes it very difficult for healthcare providers to provide safe, quality, timely patient care. This becomes even more difficult when patients who are already admitted are unable to obtain inpatient beds and are required to board in the emergency department. When this occurs, it's difficult for medical staff to provide safe care. Patient medication errors are made, and the care no longer becomes patient centered. It becomes more focused on process throughput, and the patients are the ones who get left behind. According to the Joint Commission, a boarder patient is a patient who has been occupying a bed in the ED for more than 4 hours after the consult to admit was completed. This 4 hour mark doesn't include when a patient's been checked in, waiting on lab results, waiting on x-rays. This 4 hours starts after the emergency department physicians have decided that the patient needs to be admitted. So this 4 hour mark usually is 6 or 8 hours in reality. This is a measure that is being tracked by one of the ED quality consultants at the Durham VA Medical Center. And as you can see, the boarder rates for fiscal year 2014 was 24%, for 2015 was 21%, and for 2016, so far we're at 20%. The national target for Joint Commission is 10%, and as you can see, the VA is not meeting that target. However, we are making consistent progress over the course of several years. So what we're currently working on is to try to improve those numbers. Boarding patients in the emergency department creates a ripple effect in delayed patient care. When there are no inpatient beds, it creates a bottleneck in the emergency department. Patients who are admitted stay in the emergency department, which does not allow patients in the waiting area to be seen as quickly, and therefore patients begin to leave without being treated. Also, emergency departments, when patients are boarding, are forced to implement ambulance diversion, which forces ambulances to seek medical care at other facilities for those patients. Each of these significantly impacts revenue. According to the Agency for Healthcare Research and Quality, every hour an emergency department is on diversion, the facility loses an estimated $1,086 in revenue, and a 1 hour reduction in ED boarding time results in over $9,000 of additional revenue. Also, psychiatry patients, high-risk patients such as suicidal ideations, homicidal ideations, psychoses, bipolar. Many of these patients, due to a lack of places for them in North Carolina to get treatment, causes a significant amount of boarding in the emergency department setting. And according to Nix and Manthe, 2012, psychiatric patient boarding in the emergency department alone can cost the department $2,264 per patient. Another financial impact that ED boarding and overcrowding has is when patients leave without being seen, and also patients who leave without completing treatment. And those are two different types of patients. Patients who leave without being seen means that they have checked into the emergency department, they've been triaged, but the wait time was too long for them to get back to see a physician, and so therefore they left without an evaluation. These patients, the financial impact of these patients who leave without being treated is approximately $2,500 per day. And patients who leave without completing treatment means that perhaps they got checked in, they were triaged, they saw a physician, lab work was drawn and completed, x-rays were performed and completed, yet the patient did not stay to wait for their results from their physician or to wait for their prescriptions. And this has also a financial impact of $1,300 per day. And you wonder why someone who leaving would cost the department money, and that's because typically these patients end up returning at some point to finish their care, which means that they were charged for basically 2 visits, or the emergency department physicians for patients who leave without completing treatment still are required to follow up on those visits, and therefore that means they have to, during their administrative time, research those patients and call those patients and give them their results. Currently, there is no process directed specifically at improving the flow of the hospital and decreasing congestion when there are boarders. However, in 2010, the Veterans Health Administration implemented the bed management system into the VA system, which is supposed to enhance communication between departments and facilitate patient flow. The bed management system is just a computer system that is a way of like nurse managers and charge nurses and the bed control staff communicating to let everyone know when an admission is coming in, when a patient's being transferred to a different department, and what beds are currently available in the hospital. Another aspect of the bed management system that is helpful is it gives a current view of beds that are available in the hospital, what beds are designated as isolation beds, And obviously, for veterans, we don't have very many female veterans. Therefore, it's difficult to place them sometimes. So it indicates what patients have females already in them. And because all of our hospital beds at the Durham VA, there are no private beds, they're all semi private. So it's important to know when females are in specific beds. And it also, the bed management system notifies when what beds are out of service, so that they know those beds are not available. Another system that the Durham VA Medical Center recently implemented was the concept of virtual units. Virtual units don't particularly assist in improving flow, but they do allow patients that are boarding in the emergency department to get the same quality of care as they would if they were on an inpatient unit. For example, the virtual units allow for patients to get their medications as scheduled. The Durham VA implemented the barcode medication administration system recently also, and that is not something that is used in the emergency department. That's strictly on an inpatient basis. So when patients are boarding in the emergency department, they're placed in a virtual emergency department area so that they can be implemented into the barcode medication administration system and get their medications as scheduled. Another portion of the virtual unit that is geared more toward patient cost is when, for example, if there's a patient that's admitted to the ICU, but they no longer need ICU level of care, but they do need telemetry monitoring. And if there's not a telemetry bed available or a telemetry box available, this patient will be placed in a virtual unit. Therefore, it will show up in their charges as being charged for a telemetry bed, not an ICU bed, although they're still boarding in the ICU. The Joint Commission in 2012 released a report which recommended healthcare organizations not to allow boarding timeframes to exceed greater than 4 hours. They realized that this is a significant problem. However, they did not particularly provide guidance on how to alleviate these issues. And in 2014, the Agency for Healthcare Research and Quality reported that 90% of hospitals admit to boarding patients in the emergency department. Along with the Joint Commission, the Institute of Medicine has also released several reports related to excessive wait times and overcrowding and boarding in the emergency department. The release To Err is Human, Building a Safer Health System, that was released in 1999, and Crossing the Quality Chasm, A New Health System for the 21st Century in 2001, really put a magnifying glass on the quality of care provided to patients in the hospital. And the Institute of Medicine really stresses that when emergency departments are overcrowded and patients are boarding, then patient care is no longer safe and patient safety is compromised. These are times when medication errors and adverse events are at their highest. And also, they state that patient care is no longer timely and efficient when patients are leaving without being seen and leaving without completing treatment. And therefore, something has to be done to improve process flow and improve wait times and decrease patient boarding in the emergency department setting. After doing research on the topic of ED overcrowding and attempting to improve process flow, I've provided some suggestions for improvement and processes that may be implemented into the emergency department setting, which may allow for a decrease in boarding patients in the emergency department and hopefully will improve the flow of the department and a way to get patients seen more quickly. Um, One of those suggestions would be to develop a patient flow team. One of those suggestions would be to implement PIT, which is having a physician or medical provider, such as a nursing, physician's assistant, or a nurse practitioner in the triage area. And also, the third suggestion would be to implement evidence based nurse initiated protocols in the emergency department. My idea for the implementation of a patient flow team actually came from some research I found from the Agency for Healthcare Research and Quality. They had already kind of come up with this team, but I did tweak the members of the team and exactly when it would be implemented to make it my own and to make it more appropriate for the Durham VA Medical Center. So for this particular patient flow team, the members would be the chief nursing officer, one of the bed control staff members, the chief physician for the emergency department, the ED nurse manager, and perhaps even a utilization review nurse. And this patient flow team would be implemented when there are 3 or more patients boarding in the emergency department and or when there's a known limited bed availability in-house. Each morning in the emergency department, the charge nurse is responsible for touching base with the bed control staff to get a handle on how many beds are available in-house, and that's just regular inpatient beds, telemetry beds, ICU beds, and psychiatry beds. And many times our limitations are that there are no telemetry boxes or limited telemetry boxes. Although we have beds available, there are no boxes, or there are limited ICU beds. So those are the members of the team and when the team would be implemented. The patient flow team would be responsible for evaluating the ED patients who are currently in the emergency department and determine what type of bed they might need, whether they need a psychiatry bed, an ICU bed, do they need a telemetry box, does that patient need a private room for some reason, meaning they could not be housed with another veteran, perhaps they have MRSA, C. diff, or do they need to be paired up with another patient that has MRSA or C. diff? And also, many of our patients, elderly patients with dementia or high risk patients, require a sitter with them. And so that also is another requirement that needs to be evaluated. Also, one of the other responsibilities of the patient flow team are perhaps there are beds available in house, but there's reasons why those beds are not available. For example, perhaps the beds are dirty. There are many times where our environmental services staff have set lunch breaks, and those can be in excess of an hour. So those are times when beds cannot be cleaned for, and that impedes process flow. Also, there have been times where we've been told that a patient is discharged, yet he cannot go home because there's no one to pick him up. So there are delays in transportation. Perhaps the patient needs ambulance transfer. Perhaps the patient's family is coming to get them, and There have even been times where there's been an entire day of delay because the family member could not get to the VA to pick the patient up. Another delay is that nursing staff is overwhelmed. There are times when we admit several patients to one unit in a day, and an overwhelmed nursing staff creates a massive process flow in the emergency department. The nurses will not take a report and then say that the bed's not clean when the bed in fact is. So those are also major problems and delays. The patient flow team would also be responsible for touching base with the current medical provider in the emergency department to determine if there are any other patients they know of that are potentially coming that will need admissions. For example, the clinics, we have several clinics in-house, and they send patients quite frequently to the emergency department to be admitted. So perhaps the medical provider may know that that particular patient will need an admission bed, and also other VAs transfer patients into the emergency department, and so that medical provider would also know about those transfers. So that would be a good way for the patient flow team to predict additional beds that perhaps would need to be available to accept those transfers. The second suggestion that I would have to improve process flow in the emergency department and potentially decrease overcrowding and boarding would be to implement PIT, which is having a physician in the triage area. This doesn't specifically have to be a physician. It could also be a nurse practitioner or a physician assistant, both of which we currently employ at the Durham VA Medical Center Emergency Department. The current process for patients is they check in at the information desk and they are triaged, and then they wait in the waiting area for a room to become available for them to see a medical provider. If a physician were in triage, that physician could offer a quick assessment and also offer additional medical perspective that the triage nurse may not pick up on. For example, there have been times where we had a patient who presented with an inguinal hernia that ended up being strangulated, and that patient was triaged and sent back out into the waiting area because the nurse did not pick up on those symptoms. There was also another scenario where a patient checked in with appendicitis and was also asked to wait in the waiting area, and that patient had a physician been in triage, maybe they could have picked up on those symptoms and had the patient taken straight back to a room. Another thing that the physician could offer in triage is that they could go ahead and enter orders such as labs or x-rays, CT scans, and go ahead and get those. They could send the patient to the lab, send the patient to radiology. Also, the provider could evaluate EKGs and after actually physically looking at the patient and compare that to determine whether or not the patient was having an actual emergency and needed to be brought back to a room. The Durham VA Medical Center Emergency Department is used for many things that most private or community hospital emergency departments are not used for. For example, when a patient comes to the VA and they've never been seen there before, the eligibility office sends patients to the emergency department to establish care. Emergency department physicians simply put in a consult for the patient to get a primary care doctor, and then they're discharged. Another misuse of resources is if a patient Say they have a medical procedure or surgery performed across the street at Duke or at another hospital, and they get a prescription, piece of paper on a prescription from an outside provider, dentist, surgeons, no matter what it is, the patients get a discount on their prescriptions at the VA medical center. So patients are forced to come into the emergency department, be triaged, and wait for a physician to simply rewrite the same medication order into our computer system and send the patient down to the pharmacy to get the prescription filled. These patients end up waiting 4 to 6 hours for simple things to establish care. I also had a patient the other day who was just eligible for care, came in, went to the eligibility office, and the eligibility office sent him to the emergency department. The patient simply wanted hearing aids. So the patient had to wait for a physician to put in an audiology consult because they did not have a primary care doctor. These types of things are areas where the physician in triage would be very, very beneficial. It could decrease the patient's length of stay. It could also decrease the patients who leave without being seen because they know that their labs are pending or their x-rays are pending, and therefore they may be willing to stay and wait for those results. And with all of that, it would increase the overall patient satisfaction scores. The third suggestion for improving flow in the emergency department would be to implement evidence-based nurse-initiated protocols. Along with PIT, nurses are able to implement standing orders and protocols, and those protocols could be developed by the chief medical officer and the ED nurse manager, along with some input from nursing staff. And these could be developed for patients with specific conditions or complaints, such as common complaints that present to the emergency department, shortness of breath, chest pain, abdominal pain. The nurses could initiate point of care tests such as troponins, Chem 8s. They could also implement for shorter breath patients breathing treatments, albuterol, Atrovent, and also can go ahead and put in orders for x-rays that need to be completed. The Emergency Nurses Association approves evidence-based nurse-initiated protocols in the emergency department setting due to ED overcrowding and borders and the crisis in the medical centers at this point. These nurse-initiated evidence-based protocols would be implemented when perhaps physician staffing is low and there's not a medical provider in PIT, in physician and triage. Also, when there are extra staff members such as float nurses, they can be deployed by the charge nurse out to the emergency department to begin initiating these protocols. It doesn't have to be 2 hours, but if the charge nurse notices that the waiting room is getting backed up and patients have been waiting greater than 2 hours to be seen, perhaps that could be a trigger for them to send the extra staff members out to the waiting area to start initiating these protocols. And the thing that would be nice about this is if the patient's been waiting that long, typically it takes all in the emergency department, labs and x-rays, for example, are all ordered stat, which means they should be completed within an hour. So if these are already performed when a patient gets back to the room to see a medical provider, the labs and x-rays should have already been resulted, and that way the physician can go ahead and initiate proper care. and have an idea of what exactly is going on with this particular patient. With these suggestions, there are a few risks that administrators may encounter if they are implemented. And one of the risks would be with the patient flow team. In this scenario, we are dealing with veterans, and they have fought for our country and they deserve proper medical care. And if the patient care team, specifically the utilization review manager, is evaluating a patient for discharge due to overcrowding and borders in the emergency department, this veteran may feel that they are being improperly rushed for discharge, which is a very valid point. So if this is implemented, that would be probably the biggest risk, because we want our veterans to come to the Durham VA Medical Center for care, and we need them to feel validated for being there and know that we appreciate them and that they are not being rushed, and that we want them to heal properly. Another risk of one of the suggestions is with the PIT or even the nurse initiated protocols, would be that perhaps there would be an increased potential for patients leaving without completing treatment. For example, if a patient knows that their labs have already been sent and their x-rays are completed, perhaps and this even happens now, they will tell the nurse, have the doctor call me if they find anything. That is a current problem that we have. Patients, know that all of their imaging and labs are being processed, but for example, I have patients who say, they have to go pick up their kid from school, so they can't wait, and they'll say, just have the doctor call me. That's not something that we would like to promote. So also, if the nurse initiates a protocol in the emergency department and leaves in the waiting area and leaves an IV in place, there's an increased potential that patients may mistakenly leave with that IV in place. Or we need to figure out what we would do if a patient wants to go out and smoke or go get food with the IV in place. Unfortunately, you cannot trust everyone, and it's the nurse's license on the line if a veteran goes out and injects drugs into that IV. So therefore, the nurse in those instances is required to call the VA police, and the VA police have to track that patient down and remove the IV. So that is something that we currently encounter, but would be an increased risk if we implemented these protocols. As nurse leaders, it is important to evaluate the effectiveness of processes that have been implemented. Therefore, as a nurse leader, with the implementation of these 3 suggestions, one of the things that I would do is to monitor the number of incidences that nurses report with patients leaving with an IV in place, or if they leave without completing treatment. It would be important to determine the severity of this, whether or not an adverse event occurred, if a patient left with an IV in place, for example, as I mentioned before, leaving, ingesting some type of illegal substances into the IV. It would be important to monitor the number of incidents that are occurring, and if these numbers are increasing, then obviously this is not a good process that has been implemented. Another area that would need to be assessed would be if nurses are improperly ordering lab work or x-rays, or are veering from the standing orders. So this would be something that the nurse leader would need to communicate with the chief medical officer to determine if they felt like the proper orders were being placed. And if not, make sure as a nurse leader that you're requiring nurses to use the standard order protocols, and also maybe they need to be adjusted. As far as the patient flow team, to determine the effectiveness of that, you would evaluate if the number of boarders was decreasing, and part of that evaluation would be to determine whether or not that team needs to be enacted prior to 3 or more boarders, or if that appears to be an effective number to start from. There are several ways to monitor whether or not the suggestions listed previously would actually improve process flow and decrease boarders in the emergency department. One of those ways is to measure the door to triage times, which would be patients checking in to the time that they are triaged. Another measurable outcome would be the door to physician evaluation. This would definitely improve if the suggestion of PIT, physician in triage, was implemented. The patients would actually get almost like a mini evaluation during that triage time. The nurse leaders could also evaluate and measure the left without being seen rates. Obviously, if a patient is being evaluated in triage by a physician and knows that labs and x-rays or whatever diagnostic testing is required are in process, the chances that a patient may leave will diminish greatly. Another measurable outcome would be the amount of boarders in the emergency department. Maybe good to measure that perhaps on a monthly basis. And another measurable outcome that nurse managers could track would be the patient's length of stay in the emergency department. Currently, we have a tracking board called EDIS, Emergency Department Information System, that starts timing from the time the patient is checked in, and it continues timing until the patient is discharged. So those would be measurable outcomes that the nurse manager could track to see if these suggestions, once in place, actually improved process flow throughout the emergency department. In the medical field, providers, healthcare providers, nurse leaders, staff nurses, physicians encounter ethical dilemmas and challenges on a daily basis. When the emergency department is overcrowded, those ethical dilemmas increase greatly. One of the ethical challenges that we deal with are elderly patients being in the waiting area for an extended amount of time. Many times these are our World War II veterans who, if they're coming to the hospital, they really hurt because they don't seek care for minor complaints. So it's very difficult to have them sitting in the waiting area for 4 to 6 hours. So we definitely try to get those patients back as soon as possible. Another ethical challenge is the fact that these are veterans who have served our country, and we're doing them a great disservice by making them wait for hours to be seen by a physician. So I definitely think that these implementations of these suggestions, especially the PIT, physician in triage, would greatly increase the patient satisfaction scores related to those two areas. The other ethical challenge that occurs when the emergency department is overcrowded is that our ambulances are on diversion. Veterans seek care at the VA hospital for a multitude of reasons. Their primary care physicians are there. They have discounted rates. All of their medical history and information is there. So when the emergency department is overcrowded and we're on ambulance diversion, those patients are forced to go to outside hospitals where no one knows who they are and they don't particularly care that they're a veteran. And that's very difficult. I've had patients come and tell me that because we were on diversion and they had to go to another hospital, that they could not get um, that hospital visit paid for, which is also another ethical dilemma that we deal with related to emergency department overcrowding, specifically at the VA hospital. While I was researching for this project, um, the verse from Colossians 3:23 kept entering my mind. It says, "Work hard and cheerfully at whatever you do, as though you were working for the Lord rather than for people." Um, this is very true, and as healthcare providers and Christian nurse leaders, we should take pride in our jobs as nurses and nurse leaders, and we should try to be as efficient at our as job as possible, and therefore improving the process flow in the emergency department and implementing even one of these suggestions would be great and wonderful to see it actually be effective, and to help our veterans get seen more quickly. So, in conclusion, emergency department overcrowding has a significant financial impact on the healthcare system overall, and specifically in the Durham VA emergency department, there is not a effective strategy currently in place to improve patient flow. And since this is regulated by JCO for boarders to be less than 4 hours, I really do feel that the implementation of either the patient flow team, a physician in triage or PIT, or nurse initiated protocols, if not all of these, perhaps one of these, would significantly improve patient flow. And there are very simple ways to monitor any type of improvement. As I stated earlier, door to triage, door to physician evaluation, the number of left without being seen, and most importantly, the number of boarders in the emergency department, which hopefully, if implemented, would each of these would significantly decrease. Thank you for your time.